So now I would like you to invite you to my speech about clinical experience with UED-A video laryngoscope.
On this slide, you can see the device. It consists of a monitor, a display monitor, with a handle that is in fact a camera, and a single-use blade combined with the cover for the handle. This is quite interesting, but also popular possibility of using video laryngoscopes. The UED video laryngoscope has possibility of taking pictures and recording the videos. This, in my opinion, is very important regarding the nowadays tendency to have full medical history of the patient. So you can record the intubation efforts and keep them in the medical history of the patient as a proof of how the intubation was performed. This may be important regarding not only the possible suing and some claims, but also regarding the future operations, future medical procedures that can be done on this patient. So you can have the picture of the entrance larynx, and if there are some difficulties, you can have those as some clue, some advice for future intubation performers. On this picture, on this slide, you can see the comparison of UED-A video laryngoscope and very popular and commonly used other video laryngoscope, which is McGrath-Mag. On the first look, you can see that there is a difference in shape of a blade of video laryngoscope. UED video laryngoscope has a blade that is more similar to typical Macintosh blade laryngoscope. This may have also some influence on clinical performance, because the providers, intubators that are familiar and trained with the use of typical Macintosh blade laryngoscope potentially may learn faster how to use video laryngoscope that is more similar to typical Macintosh blade laryngoscope. On this slide, I compared the single-use disposal parts of these devices. You can see that a single-use blade of UED-A video laryngoscopes consists of a cover for the blade and the cover for the handle. The blade, single-use blade for McGrath-Mag covers only the blade. So, of course, we can say that devices, video laryngoscopes, should be cleaned properly after each use, and the probability of some crossover infections are very limited. However, it may happen that because of some other additional factors, the handle of the video laryngoscope can not be cleaned properly. And if the cover is only for this blade, there can be some risk of possible cross-infection. If you have the single use blade together with the cover for the handle, it increases patient's safety regarding prevention from possible crossover infection. Another interesting issue is the size of the blade, the diameter, and this determines the mouth opening that is needed for insertion of the blade. On this picture, you can see that the blade, single-use blade for UED-A video laryngoscope is thinner than the single-use blade for McGrath-Mag video laryngoscope. From my clinical experience, I can say that the blades that are thinner are easier to insert in the mouth of the patient, especially if there are some limitation of mouth opening. So as you can see on this picture, in my opinion, the use of UED-A video laryngoscope should provide easier insertion of blade in the mouth of the patient because of diameter of this blade. Another interesting thing is area of visualization and quality of display. On this picture, on this slide, you have the comparison of those monitors display of those video laryngoscopes. And on the first look, you can see that there's a difference between those video laryngoscopes regarding the area that is visualized during the observation of entrance to larynx and surrounding tissues and structures. The quality of display, also you can see that there's some difference with this, and the details that can be shown and displayed, visualized by UED video laryngoscope is definitely higher. And what is the clinical influence of this area of visualization? If you have a wider area of visualization, you can have a better picture of the surrounding tissues, surrounding structures of entrance larynx. So it may prevent from possible complications regarding the some misleading of a tube when you try to insert in the larynx of the patient. So if you have a wider area of visualization, is definitely better and safer for the patient. Now I will show you a few videos about clinical experience with this device. The first one is with the morbidly obese patient with the neck circumference 59 centimeters. You know that neck circumference is the best factor that suggests, that indicates possible difficult intubation in morbidly obese patient. In this case, we had patients like this. And as you can see, although the insertion was a little bit longer than in non-obese patient because of limited space in the mouth of the patient, this is good example of this, what I said about the diameter of the blade. If the blade is thinner, the smaller diameter, that it's easier to insert it into the mouth of the patient. As you can see in this movie, The intubation was fast and traumatic in this patient. The very fast intubation, this is important also because in those patients, the oxygen reserves are very limited and the intubation must be performed quite fast to prevent from desaturation of the patient during the intubation efforts. Super obese patients, they are met when the BMI is over 50 kilograms per square meter. And this patient had 180 centimeters high and 180 kilograms of body weight. As you can see on this movie, the insertion again was quite easy because of the diameter of the blade. Display visualization of entrance larynx was perfect and the evaluation was very fast, which, as I said, is very important in patients with high BMI, with a very increased body mass because of the fast desaturation, possible risk of fast desaturation. And not only obese patients can have some possible difficult intubation, also patients with malampathy class 4. Here you have the patient with this malampathy class 4. And as you can see, this patient was, when intubated, the display was not ideal, but still was enough to intubate this patient very smoothly. I'm sure and absolutely convinced that if we try to intubate this patient with the standard Macintosh blade laryngoscope, there would be some severe problems with intubation. Patients with the cervical collar, because of some injury of cervical spine, are also a challenge for the intubators. And this movie, you can see that the patient could be intubated with UED-A video laryngoscope without removing the cervical collar. This is very important regarding the safety of this patient because if we can avoid of removing cervical collar for airway management in those patients, the safety is increased. As you can see on this video, the intubation was very smooth, fast and traumatic. And the cervical collar, although there was still at place, did not influence, importantly, the visualization of entrance larynx with this video laryngoscope. Patients with difficult airway, predicted difficult.
Okay, so I'm sorry for these problems with playing videos. So just again, I will try to show you the videos. So this is the super obese patient. As you can see, the visualization is very good and the intubation went very fast. As I said, it's very important in those patients because of the possible desaturation. And the same with the patients with predicted difficult airway. So the patient with malampathy class score 4, again, you can see that the intubation is quite fast, although the visualization is not perfect. But regarding the malampathy score, I would be sure that if we use standard Macintosh blade laryngoscope, it would not go so well. And the patient with cervical collar, as I said, it's important in those patients to prevent from further complications. regarding the cervical spine. And as you can see, using UED-A video laryngoscope in this patient was very good, and without taking off the cervical collar, we managed to intubate this patient fast and effective. And predicted difficult intubation. These patients are for so-called awake intubation techniques. As you can see on this picture, a large tumor of the laryngeal entrance. The patient was anesthetized locally with the lidocaine spray. As you can see here, the patient is breathing, and the intubation was possible with this UED-A video laryngoscope. So it's very good alternative for fibroscope in predicted difficult intubation for awake technique. Also in patients positioned in different positions, in non-standard positions for the operations, like for a nephrectomy, for example. And those patients, of course, usually we intubate them in supine position, and then we turn to the position that is for this operation. But nowadays it's very popular to do so-called self-positioning of the patient. So the patient is positioning himself before the operation. That is for prevention of complications regarding to the pressure of nerves and vessels. So as you can see, using the video laryngoscope, in this case, UED-A video laryngoscope provide a very good and fast intubation in the patient in lateral position. Of course, other patients like nasal intubation, and this patient, especially in patients with possible difficult intubation for the reconstructive surgery, this patient is after facet trauma and requires some reconstructive operation. But for the operation, for the surgery, it's important to intubate this patient through nasal cavity. As you can see, it's also possible to do it with UED-A video laryngoscope with no problems. And the last video that I would like to show you is, in my opinion, quite interesting evaluation of head extension during the intubation efforts. In this patient, we decided to measure the head extension with a very simple device. As you can see, it's iPhone with the measurement of the head extension. And this is a comparison with the direct vision laryngoscope. In this case, it's a V-scope, but it's direct vision. So you can say it's comparable to Macintosh. As you can see, the maximum head extension is 16 degrees. And now the colleague will do this with the UED-A video laryngoscope. In a moment, you will see the head extension in the same patient intubated with UED-A video laryngoscope, of course, successfully. And it's about 10 degrees. So the difference between those two devices, direct vision laryngoscope and video laryngoscope, UED-A video laryngoscope, is 6 degrees. You can say it's not very big, but if the patient has reduced neck mobility, or we want to avoid some neck movement, this is very important to have a device that provides the intubation efforts, that provides intubation with a very small head extension. As a summary, I could say that UED-A video laryngoscope is a very valuable tool for standard and difficult intubation, providing excellent view of entrance to larynx. Can be used for a wide range of patients and procedures, including awake intubation technique. Small diameter of blade allows for intubation in limited mouth opening. And the single-use blade with a handle provides good protection from possible infections. So thank you very much for your attention.